Hi, I'm Dr. Rajiv. Let's discuss the journal and we'll do a critical appraisal of the journal. So, the topic of today, the journal title is Comparison of Vildagliptin twice daily versus Sitagliptin once daily using continuous glucose monitoring, that is CGM. There is a crossover pilot study. So, the design is crossover design, and we have done here it is the pilot study. Now, this study is known as J Victoria study. Here, J is a state over there in Japan. Okay, so we'll discuss how the name J Victoria came. So, these are the authors: Masaya Sakamoto, Rimei Nishimura, and like that, right? So, I want to discuss you first, like what is the why I'm my research question was and why I've selected this topic. Diabetes, as you know, like it has an unmet need, yes, because tendency of earlier onset of type 2 diabetes in Indian population suggested with an accelerated risk of developing of complications. There are many kind of complications we know, and our aim was to reduce the microvascular and macrovascular complications. We have discussed about this before also, so we have seen this slide also, like Indian diabetes, what's the progress rate. We have seen this nephropathy, neuropathy and retinopathy in the 17, 13 and 18% of the population, and type 2 diabetes is nearly 20 years ahead of the West because of the short stature, lifestyle, like this smoking, hypertension, overweight, LDL level is more. So also we Indians have, in Asians we can say, even in Japan, there is decrease in the insulin secretion. In the West there is insulin resistance which is causing diabetes, but in Asian populations including Japan also, it is because of less insulin secretion. Now the abstract was given as in the background. In the background of the abstract, it is written that no previous studies have compared the DPP-4 inhibitors, vildagliptin and sitagliptin, in terms of blood glucose levels using continuous glucose monitoring and cardiovascular parameters. As they said, no previous studies, but I have seen like this. It was published in 2012. So 2009 I have got an article, and 2011 I have got an article which have a similar studies, right? So I think this is something wrong. They shouldn't mention this kind of thing. Now in the abstract, in the method portion, 20 patients were taken. So it's a pilot study. 20 is a good number. So, and then from there we are getting this actual sample size, right? So the 20 patients with type 2 diabetes mellitus were randomly allocated. Okay, randomization has been done to groups who received vildagliptin and then sitagliptin and vice versa in the second phase. Patients were hospitalized at 1 month after starting of each drug, and continuous glucose monitoring was used to determine these 7 points. These 7 points were measured. First is the mean, that is plus standard deviation, 24 hours blood glucose level. The second is important one, that is the mean amplitude of glycemic excursions. That is, the excursions means basically the deviations. Okay. Fasting blood glucose level, highest postprandial blood glucose level and time, increase in blood glucose level after each meal, area under the curve for blood glucose level more than 180 mg per deciliter within 3 hours after each meal, and area over the curve for daily blood glucose level less than 70 mg per deciliter. Now they have also calculated these parameters: HbA1c, glycoalbumin, 1,5-N hydroglucitol, immunoreactive insulin, C-reactive immunoreactivity, this is important, CPR, C-peptide immunoreactivity, brain natriuretic peptide, that is BNP, and PI1, that is the plasminogen activator inhibitor 1, and urinary CPR levels. So CPR is the C-peptide immunoreactivity level. Okay, C-peptide immunoreactivity. In the result portion, they have discussed about that the mean 24-hour blood glucose level were significantly lower in patient taking the vildagliptin than the sitagliptin. Also, in patient taking vildagliptin, the MAGE was significantly lower. Okay, that was discussed, and they have said there is no significant difference in the plasma HbA1c level and other parameters like BNP, CPR, and PI1 level. Okay, so we'll discuss this. In the conclusion part, they have written the same conclusion as there in the text as in the abstract. That is, it shows that the mean 24-hour blood glucose, MAGE, and highest blood glucose level after supper and hyperglycemia after breakfast were significantly lower in patient with type 2 diabetes mellitus taking vildagliptin than those taking the sitagliptin. So overall, sitagliptin is less effective than sitagliptin is less effective than vildagliptin. Okay, overall, because the major portion there were no significant difference in the cardiovascular. So there they are asking that for cardiovascular stability, and we are using linagliptin. Okay, they have mentioned in the text. We'll discuss later. So this was the basically this abstract portion. This was the abstract portion. This is the trial registration number which is given in the abstract portion, and these are the 5 keywords: vildagliptin, sitagliptin, CGM, right, and brain natriuretic peptide and PI1. So these are basically, this is the abstract portion of the journal. Now, introduction part, if you'll see, they have written here that the number of patients with type 2 diabetes mellitus is rapidly increasing worldwide, especially in Asian countries, because of an aging population and changes in dietary habits. This is important. The short-term aim of diabetes treatment is to control of the blood glucose level, and the long-term aim is to avoidance of the complication of diabetes. Now, the current diabetes treatment programs aims to lower HbA1c level. However, recent clinical studies have found that hypoglycemia, this is very important, I'll change the color, hypoglycemia as well as postprandial hyperglycemia are also associated with the development of the cardiovascular disease. This is important, and we have the drugs we are using there. They both are DPP4 inhibitors. Now they enhance the actions of incretin, which promotes the insulin secretion and suppress the glucagon secretion depending on the blood glucose level, thereby improving the blood glucose control without inducing the hypoglycemia. So there are no attacks of hypoglycemia. It is a safe drug, it is an oral drug, and is very important. Okay, DPP4 inhibitors are considered effective for the treatment of type 2 diabetes mellitus in Asian population patients, including the Japanese patient who have insufficient insulin secretion, in contrast to the Caucasian patients who have insulin resistance. This we have discussed in the previously. Now, these people conducted a crossover pilot study named GK, vildagliptin and sitagliptin with CGM to real blood glucose control in type 2 diabetes. Here the name comes the J Victoria. J for GK, vildagliptin, C for CGM, this is 2, R for real blood glucose control, and IA for in the diabetes name only. So that is J Victoria study. Okay. Now, this is important. They have compared the cardiovascular parameters, and in the cardiovascular parameters they are using this brain natriuretic peptides and plasminogen activator inhibitor as a comparison group, which we had discussed also. Now here, just to avoid the confusion, I have compared SGLT2 inhibitors with DPP4 inhibitors. Now this is not there in the journal. Just to make sure we'll understand that DPP4 inhibitors will decrease the glucagon levels, increase the insulin secretion. It has an incretin effect, it has weight neutrality, there is have no effect on the weight. The GLP-1 and GIP both will improve, and overall it will help in the management of hyperglycemia. Whereas SGLT2 inhibitors will increase the beta cell sensitivity, and it will increase the glucagon level, and more or less it decreases the weight, and it will be acting. So they both are acting together. Okay, to decrease the hyperglycemia. But we are talking here only about the DPP-4 inhibitors. This is was just a memory recap. Now the subjects and the methods, yes, the patients, only 20 patients were taken who had poor control of blood glucose levels in spite of diet and exercise therapy for 1 month or longer, with or without any oral antidiabetic treatment, were included in the study. But they have not mentioned about the inclusion criteria. The exclusion criteria, yes, they have given. They have excluded the type 1 diabetes, severe ketosis coma patient, severe infection patient, severe trauma patient, pre and post operative patients, history of laparotomy or ileus, yes, that is pre and post operative, chronic intestinal disease associated with disorder of digestion or absorption because we are giving oral drugs, severe hernia stenosis ulcer of the large intestine, yes, pregnancy, possible pregnancy or breastfeeding, they were excluded, moderate or severe renal dysfunction were excluded. So early level of diabetes, newly diabetes people were included in the studies. Severe hepatic dysfunction patient was excluded, patient on insulin treatment were excluded, and treatment with antidiabetic other than sulfonylurea were excluded. History of hypersensitivity to any of the ingredients of the study drugs, and just to unusual of the participants for some medical reason were excluded from the study. These were the exclusion criteria. Now here you see this figure 1, this is the study protocol. Here beta-glutin and sitagliptin terms have been given, and the two groups have been mentioned, VS or SV. So first group will be vildagliptin 100 milligram per day, okay, and there will be it is a crossover design, right? So at least there should be a washout period, but nothing is mentioned over here. So that's why I have written where is the washout period. They have not mentioned over here, but in the text it was written that 4 days of hospitalization will be there. So 4 days of hospitalization will be there, and there they will be given. They have not even mentioned that no intervention will be given or something like that. They just said they will collect the blood, continuous glucose monitoring will be there, and blood examination and urine analysis will be there. Okay, and after that 4 days, again similar 1 month period will be there, again 4 days hospitalization and all. So this period they have not mentioned. They have not mentioned about the washout period, the name or anything like that, right? So this is the thing I want to emphasize. So this was the person indicates the continuous glucose monitoring on the second and the third day of hospital. Identical meals were given to all patients during the hospitalization. They have mentioned, but they have not mentioned about the washout period, and no intervention was given, and also about the how they have crossover, like half-life of DPP-4 inhibitors. It is widely ranged, so they have not mentioned that, right? So we can say T half of sitagliptin is around 12 hours, okay, and vildagliptin is about 2 hours something. So into 5 we'll see this 10 hours, because 5 T half will lead to 99% of the excretion, and into 5 T halves if you see, then it is around 4.5 days. So basically the washout period should be mentioned properly, and the person who are getting a new intervention should be relieved from the previous medication, okay, from the body, right? Now the baseline parameters, patient characteristics, if you see, the age is 55 plus minus 5 years, the gender is 13 male and 7 female. That is the advantage of a pilot study, advantage of a crossover design, because there is no confounding bias. Age and gender are they are not, because the same patient will be taken in both the studies, right? Body mass index, yes, it is 25. Diabetes duration was less, very less, short, okay. Newly type 2 diabetic is 4.5. HB1AC was 7.9 plus minus 0.7. Now in this treatment part, what they have done, they have written none and sulfonylurea, okay. But here you can see in this, I have just screenshotted. Now here you can see they have written before the enrollment in the study, 8 patients were taking a DPP-4 inhibitor in combination with sulfonylurea and 12 were taking DPP-4 inhibitor only. So how can they write this? This is wrong, absolutely. The table is here is wrongly mentioned, or I don't know what they have used. Okay. So now statistical analysis, yes, mean plus standard deviation. Paired t-test was used to compare, and all they have written about SPSS software also. That's okay. Okay. If you'll see over here, they have done the p-value and they have put the asterisk mark over here, which were significant, statistically significant results. They have shown it here, right? So these are the 4 which have been discussed in the discussion part. This was the parameters they have getting. They have mentioned this 7 parameters were used, right? Now here you can see the only urinary C-peptide immunoreactivity was significant. Rest all are non-significant if you compare both sitagliptin and vildagliptin. Now these are basic CGM charts. Okay, so nothing to see, just a new thing to understand, that because this is the future, continuous glucose monitoring is the future. Here you can see there is something called exclusion summary. This exclusion summary is actually the deviations. These are the deviations. So in this journal, you can see over here this is kind of graph which we are getting. Okay, so the bold line is the vildagliptin and the dotted line is the sitagliptin. Now when the sitagliptin, you can clearly see that 8 a.m., 12 p.m. and 18 p.m., that means 6 p.m. you can clearly see that vildagliptin is actually putting the glucose level lower than the sitagliptin. The dotted line is always nearly above the bold line, right? So overall, if you'll see that vildagliptin lowers the blood glucose more efficiently, right? Now the discussion part, yes, mean 24 hour blood glucose level and the deviations were significantly lower in the patient taking vildagliptin than the patient taking the sitagliptin. This is very important. Okay, now the reason for differences in drug efficacy of mean blood glucose level and MAGE was like, we'll see there is a 70% suppression of via the sitagliptin and 80% or greater suppression of DPP-4 activity over the 24 hours in the vildagliptin because of taking twice daily. They are using 50 mg twice daily, and there was a single dose of 50 mg sitagliptin they have used once daily in the morning. So the mode of binding is also different, frequency is different, and that's why there is a drug efficacy different. If sitagliptin 100 mg could be used, that was one of the limitations of the study they have mentioned later. If they have only used 50 mg, they have not used 100 mg at all. Now the postprandial hypoglycemia triggers the vascular disorders. We know about this. Only the urinary CPR levels variations and variations in some blood glucose were higher in taking the vildagliptin than the A. This was only thing that was significant. Otherwise, all were same. Now this we have seen. This is a repetition. Now it is interesting. I think this slide is repeated. This slide should be removed, right? Okay, now they postulate that the higher level of DPP-4 inhibitors over the 24 hours in patient taking vildagliptin compared with patient taking sitagliptin inhibits the destruction of incretin. That is, I've said GIP, right, and GLP. Now, which enhances endogenous insulin secretion, thereby improving the MAGE and achieving a more stable reduction in blood glucose level. A relationship between MAGE and oxidation stress has also been reported, suggesting that the improvement of MAGE by vildagliptin administration might suppress oxidative stress and decrease in the incidence of adverse cardiovascular event in the long term. So this was the postulation by the authors. There are limitations, yes, small number of subjects as a pilot study because of the pilot study, and sitagliptin only 15 milligram dose, because if there will be 100 milligrams there may be a different result, right? So we have no idea that 100 milligram se kya hoga, right? Now conclusions, basically they are the same, there was no significant level of this, right? So let's critically evaluate it, right? So let's critically evaluate the thing, right? Now if you see a pilot study, if you consider a pilot study, the name of the pilot study must be there in the study title. This is done, but in the introduction, in the background part, there were no mention of the pilot study. In the method section, where they have to actually analyze the sample size, they have to analyze the validity of the study, the criteria for the participants, inclusion exclusion criteria, and there are many things which were actually lacking, which was supposed to, they have made a pilot study, so their main aim was to make a sample size and many other things to calculate for the main study, but they have never mentioned the name of the main study, what they are going to do, and they have not even calculated about the sample size. Also in the results section, the validity of the described points in the method sections and points to be modified are described, should be described, but here yes, there were few points which were taken, but basically they have not discussed properly. The discussion should be focused on determining whether or not main study is feasible or not. They have never mentioned this. Okay, and lastly, whether or not the main study is feasible based on the pilot study determined or elaborated, it is not mentioned. So overall, if we will critically evaluate a pilot study, then only one of the criteria out of 6 as per Thabane, based on the consort statement, only 1 out of 6 criteria is fulfilled for a pilot study. Okay, now this is the study, this is the article, about the article we'll see. This is the DOI. Okay, we can cite this article with the help of this term, Sakamoto. This is the main primary author et al. And this is the journal, Biomed Journal, BMC. It is a thorough peer review articles, open access, and it is included in the this machine. So now you can see about the journal. What type of journal? It is an open access peer reviewed journal. Year of publication was 2012. We have discussed like 2009 and 2011 also there were studies. Now it is indexed in PubMed, Scopus, Google Scholar, and Chemical Abstract Service, right? The impact factor is 7.25, issue number is 11, volume number is 92. The page number, yes, 7 pages were mentioned. Financial support was from the Japan Diabetes Foundation. Conflict of interest was none. About the authors, yes, the name was there, the designation was there, and the institutional attachment was also there. This is the GK University of School of Medicine, and also the author's information was available in the end of the article. The abstract we have discussed properly. It was structured, informative, and comprehensive. It is the gist of the whole text. Yes, information given in the abstract matches with the text. It is completely true. Only one table was some mismatch. Keywords were 5 in number and it was appropriate, and abbreviation was mentioned in the text. Whatever the abbreviation they have used, they have elaborated it at the closely only. The title of the article, yes, does it indicate the topic and the focus of the study? Yes. Title is meaningful and complete? Yes. Reflect aim and objective of the study? Yes. Does include important variables which are intended to be measures? Yes. Study population mentioned was 20 because of the pilot study. The introduction, yes, it was meaningful, concise, and well explained, and the need of the study they have also introduced. Material and methods, where and on whom did the study take place was mentioned. Study design was pilot crossover study. It was basically a crossover design. Inclusion criteria was not mentioned separately, but exclusion criteria was there. There were 13 exclusion criteria. presented in a logical and meaningful manner. The sample size, the study population was mentioned 20. Ethical approval and clinical trial registration number was also there. Results were presented in a logical and comprehensive manner. It was based on aims and objective, presented in table and tabulated and text manner. The data matches with the text except for one table, right? Discussion highlights the importance of the findings of the study. Explanation of all significant findings concerned impacting study were mentioned. Comparison is done with other studies in the discussion part. Yes, limitations were mentioned. Good. Now the conclusion is they have mentioned it properly and there was no data sharing. These are the references in the Vancouver style. This is the Vancouver typical style. These were the references. There were total 28 references. Okay, this is Harvard referencing style, just to compare it. Now, yes, now this is the summary, right? This is the summary. Comparison group, right? The patient population was 20 and type 2 diabetes with poor control in spite of diet exercise for one, right? Now higher level of VA kya karta hai? It enhances the endogenous insulin secretion, improving the MAGE and more reduction in the blood glucose level. Now this was the 7 parameters which were there, and CGM showed that mean 24-hour blood glucose, MAGE and highest blood glucose after supper and hyperglycemia after breakfast were significantly lower in patient type 2 diabetes mellitus taking vildagliptin than those of the sitagliptin, right? So this was the results basically, and I want to thank you for patiently listening to me. Good night.